Hi, I'm Dr. Joseph Romagnuolo. I'm going to talk to you a little bit about our paper in GIE entitled Accuracy of Contrast-Enhanced Harmonic EUS using a perflutren lipid microsphere contrast agent, a second-generation agent named DEFINITY. This is the first American series using a second-generation contrast agent for EUS. The co-authors of the paper include Brenda Hoffman, Robert Hawes, Stacy Vela, and Vignesh Shivakumar. And the study was done at the Medical University of South Carolina in Charleston at the Digestive Diseases Center. I'm an associate professor of medicine, and I am the director of clinical research. Now, CT and MR have long used a perfusion dimension to their evaluation of the pancreas. In fact, a non-contrasted CT for moderate or small-sized pancreatic tumors is almost useless for detection. EUS, on the other hand, has really not used a perfusion dimension to their imaging, mainly because EUS without contrast is pretty good at detecting tumors. However, restaging procedures and lymph nodes that might be inaccessible without going through primary tumor and subtle liver lesions or pancreatic lesions within chronic pancreatitis is still a difficult area for EUS, and adding a perfusion dimension to look for a hypoperfused tumor might be very helpful. For this investigator-initiated project, we sought financial support and drug support from Lantheus Medical Imaging for the contrast agent, and we obtained a prototype echo endoscope from Olympus America. We also used an Aloka Alpha 10 ultrasound processor, which allowed us to use the extended pure harmonic detection and the arbitrary phase control transmission that we used in this study. In this pilot study, we looked at 30 sites in 21 patients. About a quarter were nodes and about 3/4 were masses, and about 2/3 of the masses were pancreatic masses. About half of all the lesions were malignant, as defined by either having positive cytology or pathology, and the benign lesions were followed up for 6 months to ensure that they were benign. We found the ideal mechanical index setting. We then looked at the sites with conventional EUS and with a contrast-enhanced EUS, and the endosonographer rated the lesion between being very likely benign, very likely malignant, before and after the contrast agent was given, and then an FNA was done as indicated in standard care. We then compared the accuracy of those results to the final diagnosis. The positive predictive value and negative predictive value of the two types of imaging were similar at 80 to 85% and 100% respectively. There was a trend towards having more undecided cases in the conventional EUS compared to the contrast-enhanced EUS. And when you took that into account and called those undecided cases as errors, the accuracy was slightly higher with the contrast-enhanced EUS. Apart from that, there were 2 cases in which management was changed significantly. One of those was a hyperechoic liver lesion in a patient with pancreatic cancer, and the other was a mediastinal mass. And contrast-enhanced EUS was able to identify the former as a vascular lesion quite clearly, and the second lesion showed up as a solid lesion because it had internal perfusion and separated that nicely from being a cystic lesion. That's important for the latter because we would rather not sample a mediastinal cyst because of the risk of mediastinitis. We saw several perfusion patterns in the study with central hypoperfused areas or perfusion defects being labeled as suspicious. And a summary of those perfusion patterns is given in the article. So second-generation agents have a wider window between producing simple linear mirror reflection echoes and having so much force that the bubbles cavitate or burst. Allowing a intermediate mechanical index or ultrasound force to be used with a second generation agent allows you to produce nonlinear echoes. And nonlinear echoes occur because bubbles resist compression at some point and then reflexly dilate to a greater extent than they are compressed. And so that reflection is not a mirror image or linear echo. And those nonlinear echoes produce second and higher order harmonics, which can be detected potentially with advanced probes and processors. The second and higher order harmonics will only come from the bubble-containing tissue, which is the perfused tissue. And so you can separate out perfused and non-perfused tissue. There are other ways of separating out perfused and non-perfused tissue other than simply filtering out the lower harmonics, which makes you lose data. And you can use multiple pulses, either inverted or in phase or out of phase, and look at the predictable response that you get from a non-bubble containing and non-perfused tissue compared to the more erratic, unpredictable, nonlinear responses you get from the perfused tissue that contains the bubbles. DEFINITY costs currently between $100 and $150 per vial, and we use less than a vial per case. And that's well under the cost, the current cost of an FNA needle, for example. In terms of the time that it involves, the arterial phase only lasts for 30 seconds. And so the entire arterial and venous and post-venous imaging is complete within about 3 minutes. And so it adds minimal time to the case other than setup, etc. None of the contrast agents are FDA approved for abdominal imaging. DEFINITY, the one that we used for this study, is FDA approved for cardiac imaging. And so it's an off-label indication. And for the study, we had an IND waiver from our IRB in order to look at this agent in abdominal imaging. Elastography is a competing technology. And elastography uses the firmness or stiffness of tissue to try to tell whether something is benign or malignant by using a degree of deformation or speckle motion. The limitations of that approach are that not all firm or stiff tissue is malignant, especially in chronic pancreatitis where a benign area of inflammation can be quite firm. In addition, the color pattern that's used to provide a spectrum of firmness within the field is actually relative to whatever else is also in the field of view, and so the actual colors used can vary depending on whatever else is in the field of view at the time. A German pilot study looked at this and found that elastography was not helpful at all in differentiating chronic pancreatitis from pancreatic cancer. A multi-centered study found that there was about a 10% increase in specificity in the pancreas, so a modest increase in accuracy. But it was very helpful actually in lymph nodes where stiffer, firmer nodes were more likely to be malignant and improved quite a bit on conventional EUS in that regard, and it's quite promising for that indication. One limitation to contrast EUS is that not all malignant tumors are hypoperfused. Endocrine tumors, for example, and lymphomas can actually be hyperperfused and might not have a perfusion defect. In addition, if you have a necrotic area in the center, or if you have a cystic area in the center of the lesion, then that will cause a perfusion defect in the center and could cause you to mislabel something as malignant. However, adding a perfusion dimension to EUS seems logical. It seems to be very good at differentiating a vascular lesion from a solid lesion, or a subtle, cloudy, cystic lesion from a solid lesion. For those indications, it seems very good. And then for indeterminate cases, such as a subtle pancreatic mass or an inaccessible lymph node, having a perfusion image of that lesion may help one decide whether or not it's worth to FNA or whether to call the lymph node malignant if it's not accessible. It also may highlight subtle liver lesions that might be isoechoic or invisible to ultrasound, and the difference in perfusion may allow that lesion to pop up in the liver and look more prominent. It may also help us guide an aspect of the tumor to FNA, and that needs to be further studied. It also gives us some idea of the vascularity of the tumor, and that might be important in terms of picking the most appropriate treatment for that tumor. So in summary, I hope you're just as excited as I am about adding a perfusion dimension to EUS. And I hope I've given you an overview of how contrast microbubble agents work in EUS, and also given you a brief outline of what our paper in GIE entails. Thank you.